It's an honor to be here with all of you dealing with this really important topic. I'm going to talk about a very specific part of the crisis and how we are designing, testing, and scaling solutions to ending child wasting in humanitarian settings. And we are all here and have heard about the deadly hunger crisis that we're facing. What I'll speak about is children who are at most risk in this crisis for numerous reasons. And specifically, even not just overall children who are facing hunger and the millions who are facing hunger, but actually acute malnutrition. So WFP estimates that 60 million children globally are suffering from acute malnutrition, and this is critical outside of hunger, not just because children are hungry, but because acute malnutrition or wasting, which is where children's weight is dangerously thin for their height. And these children are 11 times more likely than their peers to die. And if they don't die, they are very likely to have long-term cognitive and physical consequences. So it's a very specific part of the food crisis. And the biggest challenge in this is not just the large numbers, 60 million worldwide and 18 million children in humanitarian settings, but that despite having a treatment that is very effective, so over 80% effective, which is a peanut paste fortified by micronutrients that children recover by within weeks, only 1 in 5 children are actually receiving this treatment. So 80% of children who are acutely malnourished are not receiving a treatment that is 80% effective, leading to 2 million deaths annually. So IRC, the International Rescue Committee, where I work and oversee research and innovation, it works in 40 different countries in humanitarian settings, and we are largely an implementing organization. So we implement programs for health, for safety, for education, economic well-being, and power. But the reason that we invest in research and innovation is because the current interventions that we have are not good enough to reach people in general in need. So the need over the last decade, as you all know, in humanitarian crisis has increased. The funding has not increased at the same rate, and in general, we are not reaching people in humanitarian settings, and so the need to design, test, and scale new interventions is critical. So I'll focus on the research and innovation that we've done to end child wasting or to address this crisis of acute malnutrition, and specifically focus on a simplified combined treatment protocol that we developed and tested, a randomized control trial that we used to test it, and then operational research that we have done in multiple different contexts. We've also been investing in supply-side solutions on the actual pumping out or ready-to-use therapeutic food and predictive modeling. We've also done work in anticipatory action that's been mentioned, so predicting, that I'm happy to speak about, but I'll focus on this simplified protocol right now. So a major barrier that we have to reaching all of the children who are acutely malnourished is a system that is unnecessarily costly and complex and inefficient to deliver treatment to children. So we've developed a simplified protocol to reach the last mile or to reach these children. The traditional approach is a bifurcated system that divides children into two: severely acutely malnourished children and moderately acutely malnourished children. It uses a complex weight-based diagnosis, so height for weight, which doesn't seem that complex, but in certain contexts it is, and different dosing of this peanut paste that is complex. It uses 2 different treatment protocols that are delivered by 2 different UN agencies, 2 different treatment products that are ultimately very similar. And these are actually, and really importantly, delivered at 2 different points of service. Despite this being a continuum condition, Often these points of services are very far away from where people live, and so access to get to these points of services is very difficult. And again, by two different agencies, many different partners. What we've developed over many years is a simplified approach that uses one simple diagnosis, which is the middle upper arm circumference, which tracks along in the same way as the body and weight, the weight for height. A very simple dosing, which you receive 2 packets if you're under one cutoff, and 1 packet if you're over that 115 millimeter cutoff. At one point of service, it can be delivered in facilities or it can be delivered in communities with one treatment product. And this can be delivered very accurately in communities and close to home, and does not need to be delivered in facilities. We tested this approach. We did many different iterations first, but we tested this approach in a randomized control trial that showed that this simplified protocol is just as effective, or in health speak, non-inferior to the standard protocol for treatment. So we tested 4,000 patients, children in both South Sudan and in Kenya, and showed that children who were treated with this simplified protocol recovered at the same rate, so about 76 versus 73%. The deaths, very small number of deaths, but the deaths were the same in both the simplified protocol and the standard treatment. The recovery time was the same at about 10 weeks. And there's no evidence of differences in either other outcomes, including non-response treatment, defaulting, or average daily weight gain. So the simplified protocol is essentially as effective as the more complex treatment. We not only did the randomized control trial, but then we have been rolling this out operationally in many different contexts that are quite different operationally. So we've tested this simplified protocol in different operational settings, treating over 90,000 and tracking them across 5 different countries, including Chad, Mali, Central African Republic, Kenya, and Somalia. And this operational research shows that this simplified protocol is consistently effective, as we showed even at higher rates than in the randomized control trial. So 3 things I want to emphasize. 1, recovery is high. Recovery rates range from 85% to 95% recovery for children in this operational research where the treatment was not highly controlled. And this is well above the SPHERE standard or the Humanitarian standard of 75%. The second thing, a concern is about the most vulnerable of these vulnerable children. But vulnerable children recover well with this simplified treatment. So recovery rates are over 80% for children who have severe wasting, for children who have concurrent wasting and stunting, both at the same time, and for the youngest patients. So we saw high recovery rates even for and this operational research allowed us to look at many different subsets of children. Third, community health workers can deliver a simplified protocol. So when we look at the delivery of community health workers compared to those delivered in facilities, we see high recovery rates for community health workers as well. In Mali, 94% of children who were treated by a community health worker recovered. And then in addition to this being effective, the simplified protocol, our research also shows that these simplified treatments are more cost-effective than the standard treatment. So treating a severely wasted child using this simplified protocol costs 24% less per child in our study in Mali. And this is largely driven, the reduced cost, by the reduction in use of the ready-to-use therapeutic food, the peanut paste, and by being able to treat more children by using the simplified protocol. Now, the reduction in use of ready-to-use therapeutic food, which is actually about 40% reduction for severely malnourished children, is not just important because of the cost, but it's important because the supply of ready-to-use therapeutic food is also a major barrier to children being treated. Getting that supply to communities is difficult. There are often stockouts, and so actually reducing the amount that is needed is critical for increasing access. This means, and we are also looking at different ways to increase the supply chain including buffer stock, including new formulas for ready-to-use therapeutic food that allow for local production. But reducing this as a first step is really critical. We're also looking at predictive models so we can understand better which children are not going to recover and use the data to better predict what children are needed. So I'll end just by saying the research is very clear on the simplified protocol, but moving from that design test to actual scale, as you all know, is difficult. The uptake of simplified protocol has actually been slow and patchy. It's been used in now 30 different countries, but it's often temporarily used or in small geographic areas. The global guidelines, WHO guidelines, allow the use of simplified protocols, but only in exceptional circumstances, not as the rule. National programs are actually more willing to take up innovations more quickly, but they're constrained by global guidance, and particularly by funding that is bifurcated, still in the system that divides children by severe and moderately malnourished children. So the bottom line is that despite having a more effective solution, treatment coverage has not significantly improved. So to translate the science into impact, we need commitment, accountability, and financing. And I'd argue this is true not just for the simplified protocol, but in general for the science to translate into action. One is setting targets with teeth or with accountability. So this allows funding and accountability of stakeholders to follow. At IRC, we've argued that we should try to flip the 80-20, flip the gap of 80% right now to 80% coverage by 2030. Second, we need to drive uptake of innovations through nationally led strategies and plans and allow those plans with the contextual knowledge to then drive what stakeholders and funding delivers for these national plans. And third, we need to lock in sustained, predictable funding. Wasting is treated as a humanitarian issue, even though the global numbers have stayed very high over the years. And so funding is short and unpredictable, which is very difficult to actually plan for treatment. And finally, given where we are, I thought I would mention the powerful coalitions when researchers, policymakers, and faith-based communities can come together against global injustice. We've seen it with HIV, we've seen it with debt relief. And so within this very complex food security situation that we'll be talking about, there are many different issues to address in terms of prevention, but calling out wasting is really critical for the most vulnerable children, and demanding commitment and accountability to act on the science and scale for known solutions is a matter of social justice. Thank you.